Exploring diagnostic and therapeutic implications of endoscopic mucosal resection in EUS-staged T2 esophageal adenocarcinoma. Introduction. The incidence of esophageal adenocarcinoma, EAC, has increased rapidly over the last 3 decades. Although therapeutic protocols for early and late-stage esophageal tumors have been well defined, treatment strategies for clinical stage T2 N0M0 tumors, T2 N0M0, are subject to debate owing to the relative inaccuracy of endoscopic ultrasound, EUS, staging, with profound implications in overstaged patients. A minimally invasive endoscopic resection is recommended for CT1 EACs. Only when the endoscopic resection specimen shows histological characteristics associated with an increased risk of lymph node metastasis, LNM, will a surgical resection follow. For locally advanced tumors, T2 to 4, however, neoadjuvant radiotherapy and/or chemotherapy followed by surgical resection is recommended. Treatment decisions are based on the clinical tumor stage, for which imaging techniques such as EUS, computed tomography, CT, ultrasound of the neck, and positron emission tomography, PET, are used. EUS is accurate in staging T3 and T4 tumors and local regional LNM, but the accuracy is lower when it comes to differentiating T2 from T1 tumors, with a sensitivity of 43% to 55% and a specificity of 80% to 85%. In T2 tumors that are inaccurately staged by EUS, the final pathology reveals a pathological T0 to 1 stage in 21% to 63% and a PT3 to 4 N0 or PT any N1 to N3 in 19% to 50%. Current debates on the optimal treatment approach for T2 N0M0 EACs compare primary surgical resection to neoadjuvant chemoradiotherapy, NCRTX, followed by surgery. To date, no studies have investigated whether an endoscopic reassessment followed by endoscopic resection for potentially overstaged CT2 tumors is of added value to patient management. Therefore, the aim of this study was twofold. First, to evaluate the final histological diagnosis of patients initially diagnosed with a CT2 EAC on the basis of EUS evaluation, and second, to assess the value of an endoscopic reassessment by an interventional endoscopist, followed by endoscopic resection if deemed possible. Because of the potential risk of overstaged CT2 tumors in recent years, the authors have adopted a policy of being suspicious of EACs initially staged as being CT2, with a low threshold for endoscopic reassessment by an interventional endoscopist. Background and study aims. Treatment strategies for clinical CT2 N0M0 esophageal adenocarcinoma, EAC, are subject to debate owing to the relative inaccuracy of tumor staging by endoscopic ultrasound, EUS, with profound implications in overstaged patients. The authors aim to evaluate the final histological diagnosis of patients initially staged as having a CT2 tumor by EUS and to assess the value of endoscopic reassessment by an interventional endoscopist, followed by an endoscopic resection when deemed feasible. Patients and methods. 2 distinct cohorts of patients with CT2 EAC, as determined by EUS, were included: a retrospective surgical cohort of patients treated by primary esophagectomy and a prospective cohort of patients who underwent an endoscopic reassessment by an interventional endoscopist. The main outcome measure was the final pathological PT stage. Results. The authors identified 134 patients with stage T2 EAC from the surgical cohort. In 72 patients treated by primary esophagectomy, 32 of 72, 44%, were downstaged to a PT1 tumor. In 12 of 72, 17%, the surgical resection specimen showed tumor characteristics that fulfilled the current criteria for a curative endoscopic resection. In 13 prospectively identified patients with CT2 N0M0 EAC, an expert endoscopic reassessment was done. In 11 of 13, 85%, the lesion appeared endoscopically resectable and a complete endoscopic resection was performed. Histology revealed a PT1 tumor in all 11 patients, with 5 of 13, 38%, fulfilling current criteria for a curative endoscopic resection. Conclusions. In this study, 44% of CT2 EACs were, in fact, PT1 tumors. Curative treatment by endoscopic resection was achieved in more than a third of these cases. To avoid an unnecessary esophagectomy, an endoscopic reassessment by an interventional endoscopist is recommended for all patients with CT2 N0M0 EAC.